At least it was Chuck up and not the other one. All right. So I have the pleasure of working at the National Council for Behavioral Health, and we represent community-based mental health and addiction providers around the country, mostly not-for-profit. And I'm going to talk a little bit about workforce issues, was what I was asked to focus on. First, to put this in some perspective, I don't know if any of you have a hard time falling to sleep, and maybe an alternative to Ambien is the World Health Organization put out a report a few years ago that talked about a global shortage of qualified healthcare professionals. And sometimes I think we get so focused into our own world that we think, well, there's a particular problem that we're confronting in behavioral health because people just don't want to work in our industry. And I think that's true, but it's also important to have some perspective that, people would rather become investment bankers than work in healthcare. And I think that's a larger issue we've got to deal with as a country. And I've had the privilege, I travel all over the country talking to our members, and one of the biggest issues that I hear is that they cannot attract a competent workforce. And the good news about being the third on the third panel of the day is that a lot of the themes that I think are evident in making it difficult for our members to attract a competent workforce have already been discussed. The most pressing one, of course, is can you offer competitive salaries? And we did a salary survey several years ago, and I think the highlight for me was, you could make more being a manager at Burger King than you can being a manager at a community mental health provider. And I would dare to say maybe you'd have less stress at Burger King, that you're not dealing with people who have very complicated psychiatric illnesses, who lack adequate housing, family support, other issues that you're responsible for trying to address. And we think about, the pressure that our members face in recruitment when they have to compete with the VA, with hospital systems, with federally qualified health centers. And this comes back then to something that Pete Early talked about in his remarks that are, I think, at the heart of our problem is the way that our systems is financed. System, I think, is a kind word, right? We have a variety of systems, at least 50. California has 58 of its own, being, a county-directed state in which there's no central authority or direction that is provided, and certainly, underinvestment. But then also just the way we're, kind of our fee-for-service system as states have gone to integrated managed care. Another word that Pete used this morning, which I think an awful lot about, is widgets. And I think as a consequence, mental health has become a widget economy. How many services do you need to provide in a day to break even? And, I guess that's okay. I mean, I understand capitalism, but I also wonder then what does it do to things like engagement, to things like supervision, to things like trauma-informed approaches when your system does not actually reimburse you for any of that time. So certainly those are all kind of the issues. I'd like to talk a little bit at least about one way that we've tried to address that as an organization, because at the end of the day, our organization exists so that people can get the help they need it when they need it in their community, and we want it to be of the highest quality. And SAMHSA for years spent money researching evidence-based practices. And then put out these lovely manuals that tell you this is how you implement evidence-based practices. But one of the small details they forgot to include in those manuals is how do you pay for it? So you've got, lots of grants or pockets of innovation that happen across the country, but certainly that is not widespread. And I think about what Mary Giliberti was saying earlier about how do you know that people actually have the competence to provide the care that is needed. So first of all, we want to see evidence-based practices more widely available. Secondly, we think about about the variety of needs that people have and the different systems that they interact with. So care coordination is something that we think is really important. So how do people have access to employment training? As people leave hospitals, how is there a warm handoff that occurs to connect them to community-based care? I think all of you know, right? In unnecessary or unplanned readmission to hospitals, no matter what the diagnosis, is fueled by people who don't see an outpatient provider, whether or not that's a mental illness or a physical health condition. If you don't see an outpatient provider, you're more likely to be readmitted. So care coordination. And then also picking up on a theme that Pete talked about, 24/7 crisis response. Who's available in a community when someone is experiencing a mental health crisis? We can't always predict when that is going to happen. And, diversion or, kind of all those models that seek to work with police officers only work if the police have someone to take that person to, some place to take them to, right? It's diversion to something. And so we were thinking about all of those concepts and more when we came up with an idea that we've been pursuing legislatively called Certified Community Behavioral Health Clinics, as codified in a piece of legislation called the Excellence in Mental Health Act. So first of all, that there be national standards that providers have to provide comparable services, that they need to be evidence-based, that there needs to be care coordination and 24/7 crisis response, and most kind of radically for our system, that the reimbursement should actually be sufficient for people to do those things. I don't know what other part of healthcare where your physician is your loss leader. But as I travel to talk to our members now, they cannot generate enough revenue to pay for their physician's time. I was on the board of a clinic here in DC, and we were hiring nurse practitioners so that we would lose less money. Not so that we would break even, but that we would lose a little bit less. So that doesn't make any sense to me. And so the model, the payment model that we've attached to these clinics is the same ones used by federally qualified health centers, a prospective payment system, initially based on cost and a per episode payment, but then it assumes then all that care coordination activity, which so many of our members now want to do but don't get paid for. And I'm happy to talk, more about that later. So, but I think the most fundamental problem that we have when we think about workforce or capacity, access to care, is actually having sufficient reimbursement. 8 states are currently implementing CCBHC model, and I saw with 21 states reporting so far, they're reporting having hired 600 new professionals since the beginning of this initiative. A significant number of psychiatrists, addiction care professionals, and that's only 21 clinics reporting. So I think we'll continue to see that number grow. So I think rational reimbursement coupled with expectations and comparability, because I think the other problem we face as a system is that every state does things differently. I don't know how that advances us. So I'll stop and look forward to the questions later.